Can you hear us?
Perform it again. I lost the guide wire, then I try to recross, and now I do the OCT.
Yeah, I think there is one lesion that caused the chest pain, not all the three lesions.
Yeah.
And from the issue, we don't know necessarily
which one, but unless if you have, perhaps a beautiful nuclear
in this case, I would bet it was the circumflex.
Yeah.
It was the tightest one.
Esse está bem seletivo, meu campo.
So I advise you after this OCT to go immediately to the LAD, because we're going to have 5 more minutes for transmission before we go to the last case. Is Pedro Lemos here? Because I think that you wanted to share the final result for the other case.
Alex, I show the OCT margin. Okay, so what you have there is the control run of the OCT for the circ. So far, I believe there's also good expansion, good opposition. There's kind of some artifact, isn't it, Daniel?
Yeah, we have a lot of. It's interesting, the last section. So either it's a prolapse of tissue or...
Yes.
Yeah.
Yeah.
These are still
I
struts.
think we're fine. We should treat the LAD, Mark.
Yes.
What do you feel?
I think
one of the fears from the OCT, you see it sometimes too much and you can react to that. So I think that you should not react to something that you see.
This is what I was talking about.
It is really a risk
so
that you start to tackle
to
dissections that you don't need to, and tissue prolapse that usually you won't see it by IVUS so easily.
So Mark,
and now, Alex, go wrong. I will go to treat the LID.
So this is dedicated to...
I think the result of circumflex is okay.
And what is your workhorse wire?
The wires that I use is Whisper.
A Whisper.
And BHW.
We're using more and more Fielder FC, not the XT. For the STEMI patients, for the STEMI patients, it's sliding very nicely. It doesn't give you much support, but to enter to a lesion, go to a branch.
Come up here. The 3 final minutes. It would be nice to summarize the results in that left circ that everybody questioned about how severe it was from this morning. It would be great to have some follow-up on that.
Prepara balão 2020.
So I remember that you had 2 lesions in this LAD, right? One a little bit more focal distal and then a little bit more complex proximal. You intend to stent both, Mark?
It seems to be
far. Yes, you have 2 lesions, and I will predilatate. Make a predilatation to balloon 2.0, and after that I will show you the OCT. Probably I needed it to run.
Marco, for the LAD, if you want to go ahead,
I think we could just
treat and then just do a final OCT, because then we're going to waste too much time, and Carlos Pedra has to show one case before we finish the session.
Right.
So you're pre-dilating this LAD, right? Or you're going direct stenting?
Yeah.
Yes.
If you can show
actually,
us the
because we were planning to do OCT. So we needed
to me it looks like edge dissection.
We needed to change the blood for dye so that we could get good images.
Shows the angio on our screen
Only
because we
balloon
see just the
2.2.
OCT images.
0.
Angiografia, por favor.
Big picture on geography.
Mostra a geografia para ele.
Tem angiografia?
Isso.
Make angiography big, yeah.
So let's see what you're doing.
You don't have any big branches like diagonals there.
Vai.
O que você quer, Marco?
Ah, eu vou filmar então, Fabio. Pera aí. Vou filmar, Alex, para ver a lesão.
This is post
Then I pause the
dilatation.
OCT.
Post pre-dilatation. No, you know, can you skip OCT and then stent so we can see, and then perhaps you do OCT at the end? Entendeu, Marco? Faz o OCT no final.
Colocar o stent e fazer um OCT só de controle.
Okay. Then I think I needed to long stent is
A little bit more focal, and it's
3
too
hours.
long. Do we need to
3
stand there?
I wouldn't stand
33?
the most I would
33.
maybe take
Yeah.
it to open
3.33, por
or
favor.
very low pressure just to open it up a little.
You know, for this distal lesion, perhaps a gentle drug-eluting balloon there. What do you think, Pedro? Is this a good indication for a drug-eluting balloon, that distal small vessel focal lesion?
The distal LAD.
If it looks good, you leave with a drug-eluting balloon, or you would stand?
Perhaps, Alex, but I wouldn't do it.
You would?
If somebody tries that, I'm okay, but I wouldn't. I mean, it's a lot of stents. Patient will be on Plavix anyway, so I just stand it.
Oh, so stand.
So you'll stand it. How about not touching it at all? Because
That's another.
It's
Yeah,
pretty
that's a
distal.
good idea. You could just leave it there.
yeah, leave it there. You're gonna have a better flow when you open the proximal part. So
Yeah.
maybe also there is a bridge there. I'm not sure. It's hard to tell from here.
Helmut, you would use a long stent there, or stent both lesions? What would you be approach?
You put a small stent in distal lesion, maybe 11 millimeter, and proximal a long stent.
Long stent. Yeah, I think it's difficult to spot stenting for this proximal lesion. Even Gus would.
No, the proximal I think is diffusely disease. You have to.
You know, this LAD distal lesion is not, you know, you can't call it small, you can't call it distal. This LAD wraps around the apex, and I think that's a fairly significant LAD.
You would touch.
Definitely would. It requires a short stent, small stent.
Zago, you would treat that distal lesion too?
Yes, with a long stent in the proximal portion and another
tem que cobrir
short
a saída
stent
da-
in the distal
Distal.
portion. But I have a question.
Cobrir a saída da
What
diagonal.
kind of generation is the
No.
OCT used?
This is the C7. This is the C7.
The second,
Alex,
Yes.
what do you think about the
Because-
position of this stent?
because is it possible to take the information
You may miss
similar
some
with
of the
the
osteums.
IVUS,
That's better.
when the second generation is not available in the lab?
Yeah, but now we have C7, which is much easier, no balloon occlusion.
and faster in terms
Okay,
of.
okay, Marco. This is what, a 3.0?
This is,
Can you
I go
inject
to
now? If you
14.
inject now, you'll see if you are. But it's maybe too late. But
3033 and a
3-0.
Firebird.
Go.
So it's very close to the osteum.
Yes, very close. But